Fifth day, lunch is coming, another ugly face, another boring talk. No. So I'm privileged to be here because one great thing about this course is no talk is boring. They innovate, Dr. Govil, Dr. Anand, the topics every year, and the topic which was taken by Dr. Dalma, I used to take it till last year. I'm different, okay, because I also feel a bit of hunger in my tummy, so I'm gonna cut my work into half. You guys also gonna participate in this talk, okay? So, a patient with sudden onset pain in legs with circulatory collapse. How many of you are finally a DNB? Raise your hands. I'm not gonna cheer you, please. Just this much. I mean, people are like clicking like this, despite knowing that all of these talks will be there on the recording. So, how many of you are finally a DNB? One more, two more. Ah, so many black sheeps. Okay, second year DNBs? IDCCM. Cool. So, the IDCCM guys, you are going to be consulted next year. So, DNBs, they're going to take much longer time. So, what's your diagnosis? Oh, shall I go? How will you treat this patient? Thrombolysis. Okay, what makes you so sure this patient is having pulmonary embolism? Okay, this is a case. Can you read it? It's an actual case. So this guy is a allograft recipient, 2014, chronic allograft nephropathy. If you can see, baseline creatinine has been stable around 1.5. Diabetic, hypertensive. He had a history of deep vein thrombosis, for which this patient is on oral anticoagulants probably, and thrombosis can be seen in common femoral vein. Okay. Deep down till popliteal vein, and there is complete occlusion of left lower limb. Okay, so this is what this patient has come to us with. We got a ICU consult for shortness of breath, decreased output, left lower limb swelling. You can see the blood gas severely acidotic, trying to compensate as much as possible through respiratory mechanisms, but it is failing obviously. Investigations have been sent. You can look at the RBS. Okay, so everybody does echo nowadays. So before we could reach the patient, you do have a 2D echo on your side. You know, this is our advice. Give antibiotics. Continue with your immunosuppression. Heart rate is 95, saturation 100%, BP is 118/77. Urine ketones. You still say this is pulmonary embolism? What else it could be? What else it could be? Wow. My kid said this is the mic drop movement. We used to call it pin drop silence. Now it is mic drop. Am I right? I think I am. Quick, quick. Fantastic. One more. Somebody else. I've been a backbencher throughout my life, so I won't. Please don't shame me. Could be a stroke. Good. Yeah. And scissors. Yeah. Anything else? Okay, if I give you an MCQ, what will be your differential diagnosis about pulmonary embolism? What all you will say? Pneumonia? Okay, keep on going. Just one system. Think beyond respiratory. Okay, heart failure, just now. What else? Fantastic. What else? One more to go. One very important one. It is aortic aneurysm. Always think of all these possibilities, because at the end of the day, when we are talking about clinical diagnosis of pulmonary embolism, it is diagnosis of exclusion. So you exclude all these things, only then you say clinically. We are talking about clinically, and why I'm insisting on clinical diagnosis making, because we'll see further why it is important, particularly in places where you do not have echocardiography readily available and you do not also have a CTPA. Okay, so this is what our team thought. Probably we wanted to work up. We started to give, and 20 minutes down the line, this patient becomes hypotensive. All right, my team started norepinephrine, and let's see what happens. Okay, so this is what is all about. Occurs in 1 to 2 individuals, so the disease burden is not huge, but it is increasing. Why it is increasing? If you look at the third point, the moment we are talking about aging population, 1 in 100 is likely to have pulmonary embolism. Okay, and they're all going to present with probably a bit of vague chest pain, a bit of syncope, or a bit of worsening of their already pre-existing dyspnea. So unless you exclude all these possibilities, thinking about pulmonary embolism is not going to be intuitively coming to any one of us. Third thing is, there is definitely a racial preponderance, and we have always been, doubting in our minds why in Asians we do not see as many pulmonary embolism or as many sudden deaths which are not explained by any other cause. Obviously, then they will be attributed to pulmonary embolism. So probably there is the incident which is slightly less in Asians. This is usually the first step, making the diagnosis. So far we have agreed this is diagnosis of exclusion, and these are the most common symptoms. Alright, if you look at the left side, P suspected in a patient with dyspnea, chest pain, pre-syncope or syncope. I could not include that paper, but there is a beautiful paper which has come up in 2020 from American Heart Association. It's a 20-page document, beautifully written, which tells you how to differentiate a patient who is presenting with chest pain. Alright, and that's where probably something which is second number comes into picture. Hemodynamically instability is a rare, but it is a very important form of clinical presentation, because probably we intensivists are going to be invited to these patients for one of the organ failures, not otherwise. Syncope, very important finding. And why? Because those who have syncope and they have pulmonary embolism, so most of the times they do have right ventricular dysfunction, and this is the subset in whom mortality actually is very high. So in a patient who is having syncope, if you rule other things out, pulmonary embolism does become an important differential, at least clinically. So let's go further. What is pre-test probability? Which test are we talking about? Okay, anything else? Fantastic. So pre-test probability here is actually about image proved pulmonary embolism. So before we undertake any kind of imaging that includes echocardiography, we were trying to find a pre-test probability of that imaging, because that imaging is what clinches the diagnosis about pulmonary embolism. Are we on the same page? There is no other investigation, no other biomarker can clinch the evidence or the diagnosis of pulmonary embolism. So unlike you have cardiac thrombosis where you have ECG that can diagnose if there is ST segment elevation, or if the ST segment is not elevated, you have biomarkers, you can say it is NSTEMI. Pulmonary embolism needs a radiological or echocardiographic diagnosis. So pre-test is about imaging, and the pre-test probability depends not only on the characteristic of the diagnostic test itself, but also on the pre-test probability. For example, we'll see further how even echocardiography and CTPA, they can be doubtful. So if you are thinking pre-test that this patient is likely to have pulmonary embolism, and you have a CTPA which is equivocal, you will say that is positive. Versus if you have a pre-test probability of this patient not likely to have pulmonary embolism, your iffy kind of echocardiography should tell you to withhold systemic thrombolysis before you clinch the diagnosis by going further the algorithm. Are we clear? Thank you so much. You are nodding your heads. Great. So, Bell score, Geneva score, I don't think we need to go into the details, but the rule of criteria or a negative D-dimer can be used to effectively rule out PE if you have a low pre-test probability. If you have a low pre-test probability. Okay, but if you have a high pre-test probability, if you have a high pre-test probability, contrast enhanced CT angiography should be pursued unless your patient is either too hemodynamically unstable or in extremis, or probably is already in cardiac arrest with ongoing CPR, or you do not have a CTPA that can be read immediately. Okay, so with all those caveats attached, we are probably going away from echocardiography towards CTPA to clinch the conclusive diagnosis of pulmonary embolism. If my patient like ours was having a bit of renal insufficiency, or you have acute kidney injury, or you have certain risk factors, PQ scintigraphy is coming back into picture, because patient is not being exposed to too much of dye nowadays. Why? The 2019 ESC guidelines and 2022 AHA guidelines, the impetus is about avoiding overuse of diagnostic tests for pulmonary embolism, and the primary reason is you are exposing your patients to high amount of radiation. All right. So a rule of criteria are for emergency department. Unfortunately, for admitted patients, these PRC are still not validated. So we're going to have our pre-test probability. We're going to have our age-old Wells criteria or Geneva criteria, and then combine them with probably the age new echocardiographic finding, and then we can probably think. So every patient with dyspnea and chest pain obviously does not need to be undertaken to a CT suite unless we have such things. So these are the recommendations, and it is very encouraging to see some class 1 finding all across. All right. So if you have a high risk PE, which is indicated by presence of hemodynamic instability, bedside echocardiography or emergency CTPA is recommended for diagnosis. Okay, so we'll go down that a little further, and immediately if you have anything, you can start with anticoagulation with at least unfractionated heparin. Okay, mind you, but if you have a patient who is unstable without, then you need all kind of validation criteria before we start anticoagulation. So hemodynamic instability is a very important phenomena. Secondly, this is where the D dimer comes into picture. So let's go down there at the bottom. It's not recommended in patients in whom you have high clinical probability. Okay, so those you think are likely to have PE, no role of biomarker for diagnosis. Okay, you may still use them for severity assessment, will come there, but otherwise it is used for all outpatients, emergency department, and anybody who is having a low or intermediate clinical probability. Again, the caveat here is those who are admitted, those in whom sepsis, secondary sepsis is a differential diagnosis, D dimer is not useful. So we are going back to our age-old criterias. These are the recommended investigations. But let's go to this side first. Why echocardiography has suddenly lost the flavor? Is because of this. Because if it is negative, the negative probability is half. So that means every 1 in 2 may actually have, with a negative echocardiograph, a pulmonary embolism, which is still not changing the right ventricle into the strain pattern. Okay. But if you have echocardiographic sign of RV overload or dysfunction, it can also be found without acute PE because of concomitant cardiac and respiratory diseases. Two very important subsets that we are seeing pulmonary embolism nowadays are post-viral patients, be it influenza, be it COVID, and we know the chronic hypoxemia does show its effect on right ventricle. Second thing is acute exacerbation of COPDs. We know there is a bit of core pulmonale in those patients, and then obviously echocardiography, because we are talking about aging population in which the incidence is increasing, it is unlikely to help us. But CTPA has far overtaken the pulmonary angiography, which was the historical gold standard, is no more used because simply it gives you a highest radiation dose, okay, of almost 20 CV versus, and today's time you can have a radiation effective dose of as low as 30, as low as 3. So this is what is changing in paradigm, and this is what we're talking about. So present status of echocardiography is pretty simple. If you have suspected high risk PE, absence of echocardiographic sign of RV overload. So high risk PE is somebody who is having hemodynamic instability. There are two more subsets, will go there. It can definitely exclude PE as cause of hemodynamic stability. So if you have a normal right side heart on echocardiography, your patient's hemodynamic instability is not because of pulmonary embolism. We need to look out for other cause. It is not mandatory, that is why, and it may help in differential diagnosis of cause of shock. You guys do so much of echocardiography, you know how to differentiate shock one from other. Okay, if you have evidence of hypovolemia, if you have IVC variations, probably you have a septic shock which is not volume resuscitated properly. And you can also look at aortic dissection and other signs vice versa. But in a patient who is hemodynamically compromised with suspected PE, there are certain signs. We'll come to those pictures which are there in this presentation. And some of these signs are considered more probable towards diagnosis of pulmonary embolism. The most talked about sign is 60-60 sign, which talks about peak systolic gradient. and obviously you have a dilated RV, the McConnell sign where your apex doesn't contract in sync with the rest of the ventricle. So you have a pushed septum which is going towards the left ventricle, you have a dilated strain pattern, and these signs if you have in a patient, probably you can think of pulmonary embolism. This is what PRC looks like. So the exclusion criteria which can be used to exclude PE or to treat somebody not through hospitalization is this: if they are younger than 50 years, if they are not tachycardic, if their oxygen saturation is maintained on room air above 95%, if there is no swelling in either of the legs, they have not presented with hemoptysis, there is no history of surgery of trauma, there is no history of DVT, there is no use of oral contraceptive pills, particularly hormonal types. If all of them are negative, the chances of them in hemodynamically stable or otherwise is extremely low. Otherwise, you have to think about your clinical experiment. You have to find a strategy, either of them, either a Wells score, EARS item or Geneva score, to have a pre-test probability. And then obviously if they are presenting to the casualty, in the high risk ones, you will go for echo or CTPA. In the low risk one, you have to do D-dimers. Okay, they're also recommending if you can have a D-dimer cutoff values which are according to age, they go down. That means the lower D-dimer can also signify presence of pulmonary embolism. It increases the possibility, and this is how the decision tree is going to look like. So you can have one of the criteria. The idea is the entire department and the chain, the emergency physicians, your team as well as cardiologists, they follow the same criteria to define the same patient. Now is the risk stratification. We have talked about a lot. So hemodynamic instability is to be considered first thing, and there is three main categories. So massive is equivalent to high risk. Europeans, they use mostly the term massive. When it comes to Americans, they use the term high risk. So massive or high risk simply means the chances of 30-day mortality because of PE. Then you have intermediate risk or submassive, and finally is the low risk. Okay, so the second group is further divided depending on RA dysfunction and biomarker. Which biomarker are we talking about, by the way, here? No, we are talking about now troponin. So because troponin is going to tell you how much right ventricular wall is under distress. So this biomarker now is of myocardial injury, which is there because of right-sided failure. So this is what we are talking about. Okay, so this is not our anti-pro-NV. So you have RV dysfunction plus minus troponin I elevated. This patient is intermediate high risk, or you have an RV dysfunction minus biomarker, or a biomarker elevation minus RV dysfunction, that is a low risk. The reason we need to go into so much detail is because this one may be needing systemic thrombolysis. Okay, so these are how they talk about cardiac arrest, obstructive shock, or anybody who needs a bit of epinephrine to norepinephrine to maintain systolic blood pressure. They are all considered high risk, intermediate risk, and low risk. Okay, so once we are clear about that, we do a D-dimer test, and this is what we did. Okay, we saw on our echocardiography the RA-RV was almost normal. Your TAPSE was around 30, but my patient was now turning on norepinephrine. Okay, heart rate is just borderline. So we are looking at somebody who is, where does this patient lie right now? Intermediate, low risk. This patient is intermediate, low risk. Okay, are we clear?
But why TROPS?
TROPS is not given. TROPS was positive, but there is no RV dysfunction. So that is why this patient lies in intermediate, low risk, unless this patient goes on vasopressors. The moment this patient with all these findings turns hemodynamically unstable automatically. And why it is important? Because this is a dynamic phenomena. Our patient does go that line. Okay, so this is what we went for, because echo was unequivocal. We went for CTPA. Provisional report was there is a bit of filling defect that could be seen through naked eye on the right side, and this is where it comes into picture. Okay, so simplified pulmonary embolism severity index. It is used for low and intermediate low. If you look, it's a very simple one. If your age above 80, patient is having any sort of malignancy or cancer 1, chronic pulmonary disease 1, pulse rate 110, systolic BP less than 100. So the moment you have any of these, your risk stratification goes up and your patient can jump from a simplified PSI of low risk into an intermediate risk. This is what we need to be doing. So our patient was diagnosed intermediate high risk because half an hour down the line my patient was on norepinephrine. The clot burden was not causing RV dysfunction but had elevated troponin, was around 3, tachycardia, norepinephrine and need of oxygen to maintain saturation. So this is what was happening. We started low molecular weight heparin. We started to discuss with the family what can be done because this is what all it is about. This is the initial management. The huge part is primary treatment and secondary treatment. And in the first part, we need to think about thrombolytic, IVC filter, and anticoagulant therapy. What about ABC? In a hemodynamically unstable patient, why we have not spoken about ABC for now? Can anybody tell me? Yeah, please. Anybody? Somebody said something really right. Okay, so if we talk about pathophysiology of pulmonary embolism, the hemodynamic instability is primarily because of acute RV failure and it is an obstructive shock. It will not matter how you resuscitate if you use vasopressors or inotrope unless we take care of the obstruction. This thing is not going to work. Same thing happens with if we try to mechanically ventilate them, our intrathoracic pressure will go up, which will further worsen our right-sided failure. So try to intubate them only if they are extremely unstable, that is close to cardiac arrest. And obviously use anything that will not change your pressures. HFNC is coming in big way here as well because it's going to provide you with high flow. It's going to take care of the flow demand as well as it can provide you very high oxygen as well. And obviously we do not want too much of positive pressure. Okay, the advantage of NIV versus HFNC and HFNC scores is it can give you pure oxygen, 100% loose, but without too much of positive intrathoracic pressure. Same goes for in terms of volume optimization. Very careful, very small boluses only after looking at the RV and your IVC if that is possible. Vasopressor, obviously norepinephrine is the first choice. Okay, dobutamine. Why norepinephrine? Because it does not increase your PVR. Okay, epinephrine is not to be used unless your patient is in cardiac arrest. Lots and lots of centers are publishing case reports regarding VA, ECMO and extracorporeal life support, both as ECPR as well as those patients who are having high risk as a bridge therapy. Okay, so these things are coming into picture. When you talk about advanced cardiac life support, thrombolytic therapy should be considered. The only thing is, if you give a thrombolytic, we need to continue CPR for at least 60 to 90 minutes. Typical TPA is given 100 milligram over 2 hours. For pulmonary embolism, it's the longest. Shortest is 1 hour for stroke, 1.5 hour for your heart, and 2 hours is for lungs. But you give half the dose, maximum 50 milligram over 15 minutes. This is the accelerated regime. This is not endorsed by the societies, but it is spoken in every guideline like this. Okay, if you're strongly suspecting pulmonary embolism to the cause of cardiac arrest, this is what you can be doing. So these are the specific ones. So when we are talking about hemodynamic unstable patient, we did a transthoracic echocardiography. We found RV dysfunction. If yes, do CTPA, start treatment. No, search for other causes of shock or instability. All right. Treatment, obviously you start anticoagulation immediately. Then we are thinking about systemic thrombolysis. Others are surgical pulmonary embolectomy. It was done very aggressively at one point of time in USA, but it needs cardiac bypass. So now percutaneous catheter-directed treatment is coming into picture, and we can simply, with the help of interventional radiologist or thoracic surgeon or vascular surgeon, we can reach there. Obviously, ECMO is there, and it can be used in expert hands with or without us. Why low molecular weight heparin is being preferred? Because what we realize, if we are able to achieve therapeutic anticoagulation within 24 hours, which with unfractionated heparin is at times questionable. So low molecular weight heparin, which gives us far predictable anticoagulation within 3 to 4 hours, is turning out to be first choice. But most of us, when we are thinking of systemic thrombolysis, we follow UFH only. Okay. For intermediate and low one, there is enough evidence now that DOACs or NOACs are as good as low molecular weight heparin. So in those, we understand which we are talking about thrombolytic therapy. The guidelines are primarily intended to help us about other alternatives if my patient is unsuitable for systemic thrombolysis. Without hemodynamic compromise, obviously the decision tree is far longer. And when we talk about thrombolysis, they say, okay, try to use again systemic thrombolysis over catheter guided even in stable patients. DVTs, the recommendations are only about anticoagulation, irrespective of if my patient is having any kind of other situations. And most of them are, you can say, a low certainty of evidences in their clinical, their conditional recommendations. So depending on your own clinical judgment, whatever you decide, you're not going to be wrong. Similarly, when we are talking about DVT, the things change. They do no longer say you should do systemic thrombolysis rather than try for catheter-directed thrombolysis. So this, where our patient is somewhere belonging here in the intermediate one. We started heparin, 3 hours down the line, patient was worsening, was turning dyspneic, and now systolic blood pressure is dropping. So what is happening to my patient? Okay, so that is one possibility. Yes, this patient is probably now landing into RV failure, and RV failure, the moment there is any evidence, it increases mortality. So from an intermediate high risk, my patient is now high risk and is now a candidate for thrombolysis. So which thrombolysis we're going to think about? And this is what the CTPA came back as. Okay, the beauty of CTPA is it can tell you what is happening to the right side of the heart. It can tell you where the obstruction is, and it can also give you the parenchymal picture. Okay, so when we are talking of differential diagnosis, CTPA is also going to help us. So this is what CTPA says. Okay, there was significant bilateral pulmonary thromboembolism, right more than left, and probably this is what was happening. So this is called rescue thrombolytic therapy or surgical embolectomy. So it's recommended for patients with hemodynamic deterioration on anticoagulation treatment. Okay, all the possibilities are there depending on what your institution prefers or you have expertise. If you are somebody who can do a catheter guided one, it's well and good. Otherwise, try to use systemic thrombolysis. So we did catheter guided thrombolysis because we have this. What about IVC filters? Two things came in last 5 years. So it increased the baseline risk of mortality in patients who are borderline, as well as it increased the pre-existing cardiopulmonary disease. So whatever benefit was there, it was offset due to more deaths, and that's why IVC filters are not being recommended anymore with as ferocity as was there earlier. But still there are certain indications. If you have absolute contraindication to any kind of anticoagulation, they could be used. Routine use is not there, but they can be considered despite therapeutic anticoagulation if your patient keeps throwing pulmonary embolism. These are treatment risk factors which are to be considered for the second part, that is the primary treatment. And once we have done that, we understand our patient is going to improve. It's like India, we always have happy endings. So to summarize, our patient was breathless. He was likely to have pulmonary embolism. He had low well score, but D-dimer testing we thought we should be doing because initially patient was hemodynamically stable. D-dimer came out to 7,000. CT scan confirmed embolism. It did show normal right ventricle dimensions, but ultimately things changed. So in the absence of contraindications, we can manage them on outpatient department, and these are complex clinical scenarios. This is a paper from chest, so you can go through it. It will have the slide. It gives you beautifully what is to be done for special subsets of pulmonary embolism. Thank you very much. Thank you.
I think everybody is waiting for lunch.
Lunch.
So lunch is ready.
Thank you, sir.